Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is ventricular tachyarrhythmias, which include ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia occurs due to rapid discharge from ectopic ventricular focus. It is defined as series of 3 or more consecutive ventricular ectopic beats in rapid succession with heart rate more than 100 beats per minute. Ventricular tachycardia or VT may appear like this, where there are bursts of 3 or more consecutive ventricular ectopic beats separated by sinus beats. But many a times VT consists of ventricular beats only, where rhythm appears like this. In ventricular tachycardia, there is single or multiple ectopic foci in ventricles, which can be present in conduction pathway below bundle of His or in ordinary myocardium. As conduction does not occur through normal pathway, QRS complexes are wide and bizarre. Atria are activated by sinus impulses. So atria and ventricles have separate pacemakers, and there is no association between atrial and ventricular activation. This is called as atrioventricular or AV dissociation. In ECG, there is no fixed relation between P waves and QRS complexes. AV node is constantly receiving impulses from either SA node or from ventricular ectopic focus. Hence, AV node is in refractory state most of the time. Rarely, ventricular impulse reaches AV node when it is not in refractory state and impulse get conducted to atria. So, there can be retrograde AV conduction. In this case, there are inverted P waves after QRS complexes in inferior leads. Ventricular rhythm is regular and rate is between 100 to 300 beats per minute. If rate exceeds 300 beats per minute, then it is called as ventricular flutter. Ventricular tachycardia can be of two types, monomorphic VT or polymorphic VT. In monomorphic VT, QRS morphology is same in a given lead, and there is single ventricular ectopic focus. ECG appear like this. Changing QRS morphology within a given lead suggests polymorphic VT. There are multiple ventricular ectopic foci in polymorphic VT. ECG appear like this in polymorphic VT. In SVT with aberrant conduction pathway, there is tachycardia and QRS complexes are wide as conduction occur through accessory pathway. In antidromic AVRT, there is a re-entry loop in which antegrade conduction occurs through accessory pathway and retrograde conduction occurs through normal conduction pathway. In this case also, there is tachycardia with wide QRS complexes. Both these cases should be differentiated from ventricular tachycardia, as treatment and prognosis in these cases are very different. There are some features on ECG which suggest ventricular origin for wide QRS complexes and supports diagnosis of ventricular tachycardia. In ventricular tachycardia, there is AV dissociation and ventricles are activated by impulses from ventricular ectopic focus, and atria are activated by impulses from SA node. Rarely sinus impulse reaches AV node at such time when AV node is not in refractory state and get conducted to ventricles. When sinus impulse captures ventricle in capture beat, ECG appear like this, where there is sinus beat in between ventricular ectopic beats. Another feature suggestive of ventricular origin of wide QRS complexes is fusion beat. Rarely sinus impulse get conducted to ventricles, but at same time some part of ventricle is activated by ventricular ectopic impulse. When sinus impulse and ectopic impulse fuses with each other in fusion beat, ECG appear like this, where there is a beat which appear like combination of sinus beat and ectopic beat. Fusion beat is the most reliable sign of ventricular origin of wide QRS complexes. In SVT with aberrant conduction or antidromic AVRT, both atria and ventricles are activated by impulses from single pacemaker. Hence, there is no AV dissociation in these cases. While in ventricular tachycardia, AV dissociation is frequently present. So, presence of AV dissociation in wide complex tachycardia supports diagnosis of ventricular tachycardia rather than SVT with aberrancy or antidromic AVRT. There are some other ECG features which supports diagnosis of ventricular tachycardia as opposed to SVT with aberrant conduction or antidromic AVRT, like very broad QRS complexes more than 160 milliseconds, absence of typical RBBB or LBBB morphology of QRS complexes, extreme QRS axis deviation in northwest region, that is between -90 degrees to 180 degrees. Positive or negative concordance in precordial leads, which means all precordial leads either have prominent positive or negative deflection of QRS complexes, with no equiphasic QRS in any precordial lead. Josephson sign, which is notching near nadir or deepest point in S wave. RS-R' pattern in lead V1 can also be seen in ventricular tachycardia as in RBVB. In VT, R wave is taller than R' wave, while in RBVB, R' wave is taller than R wave. As you know, RS-R' pattern is also known as rabbit ear appearance. You can also remember this difference as in VT, left rabbit ear is taller, while in RBVB, right rabbit ear is taller. Sometimes it is very difficult to differentiate between ventricular tachycardia and SVT with aberrancy or antidromic AVRT. To help in making this differentiation, two criteria are designed. Brugada's criteria, which focuses mainly on precordial leads, and Vereckei's criteria, which focuses on only one lead, which is lead EVR. Points in Brugada's criteria are absence of RS or equiphasic QRS in precordial leads, RS interval duration more than 100 milliseconds in any precordial lead. RS interval is interval between start of R wave to nadir or deepest point of S wave. Presence of QR or QS morphology in lead V6. Presence of ventriculo-atrial dissociation in any of 12 ECG leads. Vereckei's criteria consist of following points in lead AVR. Presence of initial prominent R wave. Duration of R or Q wave exceeding 40 milliseconds. If QRS complexes is predominantly negative, then notching on initial downstroke. Ventricular activation velocity ratio up to 1. I know this term sounds terrifying. Let's simplify it. It is nothing but a ratio of vertical excursion of QRS complex in initial 40 millisecond and terminal 40 millisecond. I bet this is still terrifying. Let's simplify it with a diagram. Here, vertical excursion in first 40 millisecond is two small boxes, that is 0.2 millivolt, and in terminal 40 millisecond it is 4 small boxes, that is 0.4 millivolt. So ratio will be 0.2 divided by 0.4, that is 0.5. Some clinical features also support diagnosis of ventricular tachycardia. These are age more than 35 years, long QT interval in baseline ECG, presence of congestive cardiac failure, history of ischemic heart disease, history of cardiomyopathy, history of structural heart disease, and history of sudden death in family. In this ECG, QRS complexes are wide. RR interval is two large boxes. So ventricular rate is 150 beats per minute. Rhythm is regular as RR interval is constant. So this is a wide complex tachycardia. There is no capture or fusion beat suggestive of ventricular tachycardia. Let's apply Brugada's criteria to see if it is a ventricular tachycardia. There is no RS pattern or equiphasic QRS in any precordial lead. RS interval is about 200 milliseconds. There is QS pattern in lead V6. P waves are visible in lead V4. P waves are inverted and relation between P waves and QRS complexes is constantly changing. So there is ventriculoatrial dissociation. So this is an ECG of ventricular tachycardia. There are wide QRS complexes in this ECG. RR interval is constant and 12 small boxes long. So heart rate is 1500 divided by 12, that is 125 beats per minute. There is no capture or fusion beat. So let's apply Brugada's criteria to see whether it is ventricular tachycardia or not. There is RS or equiphasic QRS in lead V4. RS interval in precordial lead is less than 2 small boxes, so it is less than 100 milliseconds. There is no QR or QS pattern in lead V6. Inverted P waves are present in lead V4, but there is constant relation between P waves and QRS complexes. Hence, there is no AV dissociation. So, these ECG features are consistent with antidromic AVRT rather than ventricular tachycardia. Treatment of monomorphic and polymorphic VT is different. Treatment of monomorphic VT depends on hemodynamic status. If patient is hemodynamically stable, then patient's left ventricular function need to be taken into consideration. If LV function is normal, pharmacological cardioversion with IV procainamide is preferred. Amiodarone and satalol are other alternatives. If there is LV dysfunction, amiodarone is preferred over procainamide. If patient is hemodynamically unstable, synchronized DC cardioversion should be done starting with 100 Joule. Treatment of polymorphic VT also depends on hemodynamic status. If patient is hemodynamically stable, QT interval is taken into consideration. You must be thinking that assessment of QT interval during an episode of VT is not possible. For this, if baseline ECG is available, then QT interval can be assessed easily. Moreover, polymorphic VT has a tendency to subside and recur repeatedly. QT interval can be assessed when polymorphic VT subsides temporarily. If QT interval is prolonged, IV magnesium sulfate is treatment of choice. Isoproterenol or pacing can also be used. IV lignocaine or phenytoin can be given to reduce QT interval. Amiodarone and procainamide are contraindicated. When QT interval is normal, treatment protocol will be same as that of monomorphic VT. If patient is hemodynamically unstable, defibrillation should be done immediately. When VT occurs in patient with acute coronary syndrome, IV lignocaine is preferred. Ventricular fibrillation is completely irregular, chaotic and deformed deflections of varying height and width. There are no recognizable P, QRS or T wave. Rhythm appears somewhat like this. Patient is pulseless and death ensues within minutes if defibrillation is not done immediately. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.